All right, let's just jump right in. Welcome to today's Explainer, where we're going to explore a truly fascinating intersection. We're looking at the crossroads between 19th century historical medical practices and the incredibly rigorous standards of modern public health evidence. We're zeroing in on the origins and the evolution of homeopathic prophylaxis. It's a wild journey, really, taking us from 19th century epidemic outbreaks all the way to the strict, high-tech standards of modern clinical research we rely on today. And that brings us straight to the central tension of our explainer today. Think about this for a second. Can a 19th century observation ever actually substitute for modern vaccine? It's a massive question. When we look back at historical anecdotes about disease prevention, we really have to ask ourselves if those observational narratives can ever replace the strict clinical standards we demand today. Understanding the context of these historical claims, well, it isn't just some academic exercise. It is absolutely vital for public safety. So here is our roadmap for the explainer. We're hitting 4 main stops today. First, the roots of homeopathic prophylaxis. Second, defining the genus Epidemicus. Third, modern evidence and research. And finally, ethics and public health. Okay, part 1, the roots of homeopathic prophylaxis. Let's get into it. To really understand this history, we have to travel all the way back to the year 1799. Picture this. There's a severe scarlet fever epidemic sweeping through Königslutter. During this outbreak, a physician named Samuel Hahnemann noticed something. He observed that administering a remedy called belladonna to children who had been exposed to the disease appeared to either prevent the infection entirely or at least lighten its course. But before we get too far ahead of ourselves, we need to nail down our core definition. Prophylaxis is an action taken before disease onset to reduce infection incidence in exposed or at-risk populations. The absolutely crucial takeaway from our source material here, we have to draw a hard, absolute line between pre-exposure prevention and early acute treatment. Giving a remedy at the very first sign of symptoms to shorten an illness, that's early treatment. True prophylaxis is about population-level prevention before the disease ever even takes hold. The text is super clear that these two concepts should never be tangled up. And this brilliantly illustrates why context is literally everything. We are comparing 19th century historical accounts directly with modern public health evidence standards. Think about it. Hahnemann's observations back in 1799 completely lacked modern diagnostic confirmation. PCR tests and randomized trials were more than a century away. His findings were based purely on subjective clinical narratives and observational reports. There were no control groups, no laboratory surveillance, and definitely no randomized allocation. Fast forward to today, and modern public health relies on strict laboratory confirmation alongside randomized controlled trials that measure an actual, proven reduction in disease incidence across a population. So while historical accounts are fantastic for brainstorming clinical hypotheses, the source text clearly states they simply cannot serve as substitutes for contemporary scientific evidence and modern public health policy. Moving right along to part 2, defining the genus Epidemicus. So, how does this historical method actually build a clinical picture? Well, the genus Epidemicus isn't some universal, one-size-fits-all guarantee. Instead, it's a collective symptom picture derived from a very specific, active outbreak wave. You can't just assume a remedy for one flu strain in one city is magically going to protect people against a totally different strain somewhere else. Here's how practitioners historically constructed it. First, they collect complete, well-documented case histories from several infected patients. Second, they separate out the common diagnostic symptoms. As the text points out, a symptom like a fever might be super common, but it's poorly differentiating. It really doesn't help you find a specific remedy. Third, they identify the unusual shared features, the peculiar characteristics like distinct mental states or very specific thermal modalities. Finally, they compare all these quirky features and select the single remedy that best covers this combined epidemic picture. Let's actually apply that methodology with a practical vignette straight from our sources. Imagine a local viral fever outbreak where 10 patients all present with a sudden high fever, a red flushed face, a throbbing headache, and a complete lack of thirst. If we follow our steps, the fever is just a common symptom, right? But the sudden onset, the flushed face, the throbbing headache, and especially that thirstlessness, those are characteristic shared features. Historically, comparing that specific, very peculiar symptom picture against the materia medica points directly to belladonna as the genus Epidemicus for that one particular epidemic wave. Now, let's shift gears to Section 3, Modern Evidence and Research. This is where we pivot from those historical case methods to the incredibly strict scientific standards required to actually appraise preventive health claims today. You might be wondering, how does modern research actually protect itself from bias? We look incredibly closely at study design. First up, randomization. Was the sequence truly random to balance out known and unknown factors and reduce selection bias? Next is blinding. Because human expectations can easily skew symptom reports and follow-ups, blinding isolates the real, actual effects of the intervention. Then we have outcomes. Outcomes must be pre-specified to prevent selective reporting. Suspected illness is way less specific than a confirmed infection. And finally, attrition. This means tracking missing data to ensure the study remains balanced from start to finish. Without these rigorous checks in place, any historical or modern claim basically just remains an anecdote.
And because of those potential biases we just talked about, a single individual positive trial is never enough. Sure, a single positive trial might look amazing in a headline, but it can easily be a fluke of chance. That is exactly why modern research relies on systematic reviews, which examine the whole body of eligible evidence. Systematic reviews use exhaustive search methods to cut out selective citation. They rigorously assess the quality and consistency of all eligible studies, and they determine the overall certainty of the evidence. It's all about looking at the entire landscape of data before making massive public health recommendations that affect all of us.
Which brings us to our fourth and arguably most crucial segment, ethics and public health. This is where we really have to look at the strict ethical boundaries and informed consent required for health communication.
We have to remember that individual variation remains incredibly important clinically. No collective epidemic remedy removes the need for proper medical triage. Certain populations, like infants, pregnant people, older adults, and immunocompromised patients, face significantly higher risks during any outbreak. Because of this, they absolutely demand stronger safeguards. The sources emphasize that practitioners must follow official public health case definitions and ensure prompt referral for authorized preventative care for these vulnerable groups. And this perfectly highlights the stark contrast between responsible and unsafe communication. On the responsible side, ethical practitioners explicitly state both the evidence and the uncertainty. They actively support established vaccination protocols, they offer no false guarantees, and they provide a clear safety net and medical referral. On the flip side, unsafe communication is incredibly dangerous, like when homeopathic preparations are falsely described as vaccines. Let's be clear, they are not, as they lack defined immunological mechanisms. Unsafe communication discourages established prevention, presents historical anecdote as modern proof, and delays vital medical assessment. At the end of the day, true informed consent means allowing a voluntary choice without pressure, while clearly presenting established alternatives and official public health recommendations. Which leaves us with this final, provocative thought to conclude our explainer today. How do we respect historical insights while prioritizing modern public health safety? Samuel Hahnemann's 1799 observations are an undeniably vital piece of clinical history that show us the origins of the genus Epidemicus. But as our sources make abundantly clear, no historical homeopathic prophylaxis claim should ever delay vaccination, testing, treatment, or urgent care. We respect history by learning from it, for sure, but we protect our future by anchoring our public health decisions in modern biomedical proof, transparent evidence, and unwavering ethical standards. It's a fascinating boundary between history and science, and definitely something to think deeply about as you continue exploring medical history. Thanks so much for joining me on this explainer, and keep asking those great questions.